Hello, everyone. A big welcome to all of you online joining this Mindray Master webinar again. This webinar entitled Liver Elastography. I'm Candy Ng. My current role is responsible for the Mindray Ultrasound Luminary Program. I'm very happy to be here with you as the moderator for this webinar.
It is okay, Candy? You can...
Yeah.
Okay.
Please.
Hello, everybody. I'm Pavlos Zumboulis, a radiologist, CEO of an ultrasound day clinic in Athens, Greece, specializing in elastography. I hope that you're going to find interesting the presentations we're going to give during this webinar. Please feel free to create and ask questions. Not only for this webinar, but other questions also. For instance, is the good technology the technology I have? Do I use the right technique? That's all for now. Candy, you can go on.
Thank you, Professor Zumboulis. Okay, to begin this webinar, first of all, the entire team, the Mindray Master webinar, entire team, everyone would like to extend a sincere appreciation to our speaker for this webinar. And also thank you, everyone of you online, for your interest attending this exciting Mindray Global webinar, part 2 of liver elastography. At this moment, I also would like to say thank you to the speaker for the last webinar, which is our first webinar on liver elastography. Thank you for their lecture, providing us the most updated information and details about 2D shear wave for chronic liver disease assessment. And let's take a moment, do a quick summary of their lecture on some of the take-home message. And here is a summary of their lectures. The multi-parameter methods in evaluation of chronic liver disease, the lecture indicated 2D ultrasound is important for assessing the chronic liver disease morphology. Actually, a good 2D is the gateway, is the prerequisite for an accurate shear wave measurement. And second point, 2D shear wave now actually is part of a routine ultrasound examination on liver disease study because of its unique technology providing a quantitative KPA value for staging liver stiffness. And the third point is that color Doppler and Doppler provides predictive hemodynamic information to check if there is compensated or decompensated portal hypertension because of the cirrhotic liver and maybe other affected organs. Now, the second lecture from the multi-study in China, which indicated using STE-STQ on the evaluation of liver fibrosis on chronic hepatitis B patients. The conclusion of the report actually show us very excellent direction and guideline about the utilization of 2D shear wave elastography. The good direction is that the report actually indicated a good quality technical training program for operator is crucial for consistent, accurate shear weight examinations. And second point is a norm that between system and system, you will have overlapping different KPA cutoff value because of the company's system algorithm. And the third point of the report is that it also is a norm that between operator and operator, there is an inter and intra-observer variation on KPA measurements. So it becomes almost necessary for a department to have a 2D shear weight exam protocol and guideline for the operator to follow in order to reduce the stiffness variation in KPA. And the very last important point is the STE and STQ shear weight elastography, the performance after scientific and clinical validation, it can be accepted as a frontline non-invasive method in staging liver stiffness for antiviral treatment, as well as reducing the number of unnecessary liver biopsy. I'm sure you all will agree that all these are very practical and helpful information on a day-to-day clinical practice. Now it's my honor to introduce our faculty distinguished speaker to start the lecture for this webinar. Professor Pavlos Sompoulos, the founder and CEO of EchoMed, a leading imaging center specialized in elastography, is in Athens from Greece, which you had just met him at the beginning. And Professor Zhang Weiying is from Guangzhou, China, the third affiliated Song Yat-sen University Hospital, ultrasound department, also a leading research center for many advanced ultrasound applications. Many of us already know them, are well-known and active practice radiologists. Truly, they are the academic masters and clinical experts in the field of chronic liver disease ultrasound as well as elastography ultrasound. With that, I ask that we all give them our full attention and our good receptive spirit to welcome the first lecture by Professor Sompoulos and followed by Professor Zhang Yongying. Professor Sompoulos, welcome once again. And I would like to welcome you and now turn to you to start the lecture. Thank you.
Let's go.
Hello everybody, I am Pavlos Boulis, a radiologist, CEO of a day clinic in Athens, Greece, specializing in ultrasound and elastography. The topic of our intervention will be quantitative and qualitative ultrasound evaluation methods in chronic liver disease. This is the second webinar focusing on grading steatosis and portal hypertension, but we are going to perform a reminding of the first webinar, stating some crucial points about fibrosis staging. Then the second chapter, steatosis. After a clinical overview, we are going to pass to methods or ultrasound methods for steatosis grading. And we're going to finish this chapter focusing on NAFLD-NASH, because in this entity we can follow the transition from steatosis to fibrosis. And the third chapter is going to be portal hypertension, grading, through the invasive past to the future with color Doppler and Zeus. And finally, we're going to discuss how all those parameters can be unified and through a mathematical machine learning model. A chronic liver disease is one of the major causes of death. Accurate diagnosis of chronic liver disease as well as fibrosis grading are crucial. Many types of chronic injury acting on the liver cause this long history of epigenetic and genetic and epigenetic factors. The main of them is obesity and alcohol. And through all those years, from the normal liver, because there is an inflammatory damage, we arrive to interrupted architecture and finally to cirrhosis, meaning liver failure and portal hypertension. There are two solutions for this cirrhotic pathology: liver transplantation or again liver transplantation if the patient has hepatocellular carcinoma. But in recent years, we have the possibility and we need a tool in order to go the opposite way. If we achieve the removal of the underlying cause, for instance, viral infection, alcohol, or NASH, we can treat fibrosis and steatosis, and we need a tool in order to validate the efficiency of those entities through liver with less fibrosis, even through normal liver. This is an anatomy histology correlation and elastography correlation. Those are the hepatocytes. Most portal triads are interconnected with connective tissue. Through the different stages of liver fibrosis, you see that this connective tissue is proliferating, and at the last stage 4, this is a typical cirrhotic liver with much fibrosis around each regenerative nodule. The question is if we have the possibility to make this analogy between anatomy and histology and elastographic measurements. We are going to discuss, we have already discussed during the last webinar, but we are going to insist on some issues of grading, elastography from F0 to F4 in chronic liver disease. Let's take a case. We are going to discuss about intrinsic and extrinsic factors influencing liver stiffness measurement. Liver necroinflammatory process, a very common entity in the long run of chronic liver disease, increases shear wave elastography and sound touch elastography measurements. The real stiffness of STE measurements that corresponds to the real fibrotic content of the liver may be estimated only after the treatment and only after the recession of the inflammation is achieved. Let's take this patient with history of HBV and the recent increase in transaminases. We are going to discuss on these elastography images. You can see that the images are reliable, both reliability and mobility indexes are very good. Then you can measure, as we have done here. Of course, we are going to avoid vessels, and we see this number in kilopascal, which is of course a pathologic. This patient is inactive necro-inflammatory process of his HBV, and we are going to know the real content of the liver only after the treatment. In this patient, after the antiviral treatment, we have seen normal values 5.2. Let's discuss now extrinsic factors influencing liver stiffness measurements with shear wave elastography and sound touch elastography. This is a 56 years old patient with NASH and chronic cardiac insufficiency. Let's start our elastography examination. We see that everything is moving. This is, of course, the inferior vena cava. This is the right hepatic vein. Everything is moving. That's not good for applying shear wave elastography. And then let's pass to the elastography part of the examination to see that very different elastography numbers arrive. That also counts for the third slide. You can see that numbers in elastography measurements vary between 6 and 25. We have dilatation of the hepatic vein. We have also waveform movement and pressure exerting on the hepatic parenchyma, and following the heart systolic and diastolic movements. That means that because of those alterations in pressure inside the hepatic veins, we have ups and downs in pressure on the liver, influencing stiffness measurements. In these conditions, with this ever-changing measurements of elastography, because of the changing conditions of pressure in the liver, in these conditions we cannot have reliable elastography measurement. This is an extrinsic factor, the pressure in the hepatic veins influencing stiffness measurements. The causes of NAFLD and NASH. The main causes are, as you know, are obesity and diabetes. Keep only those two phrases of this map. Obesity and has more than doubled since 1980. And this is the number of people having a body mass index more than 30. And also there is a variability is noted in different regions of the planet. A prevalence rates of NAFLD are becoming more and more important if there is a metabolic disease. Why steatosis is important? Steatosis may guide to fibrosis. It is linked with rising mortality from chronic liver disease. And as we know, fibrosis is associated with end-stage liver disease, cirrhosis, and liver cancer. We need reliable indexes and methods to measure fibrosis and steatosis, because in many illnesses like NAFLD, NASH, there is a coexistence of fibrosis and steatosis. This index must be specific, without sampling mistakes, not influenced by acute changing, precise, inexpensive, easy to perform, and safe. And we want also each index to grade independently steatosis and fibrosis. We all know the liver-kidney echogenicity index, meaning the measurements between the echogenicity of the liver and the echogenicity of the cortex of the kidney. In this situation, the number is more than 2. That means that there is an important difference in echogenicity. But there is an important inter and intra-observer variability. Of course, this technique is operator dependent. There is a manufacturer variability with different machines. And in obese diabetic patients, this method is difficult to apply. Let's take a case, a patient with NAFLD NASH. Those are the clinical information about this patient. Those are the lab information about this patient. What is the patient's questions in clinic? Do I need a biopsy? Do I need a medication on any other test? How does this disease mean for me? And the physician's question is, does she has advanced fibrosis, meaning F3 and F4? Do I need to recommend liver cancer surveillance? Only this examination can answer both questions. The report of the sound touch elastography examination shows 8.6, and using attenuation and SSI, the number is 1,500, meaning low steatosis. Liver biopsy is not dedicated to establish diagnosis for NAFLD and NASH. The few cases needing biopsy are those where shear wave elastography cannot stage a fibrosis. Another case, those are the clinical information of the patients, and an abdominal ultrasound shows fatty infiltrates of the liver, and the patient questions, do I need a biopsy? Do I need medication or any other test? And the physician questions, does she have advanced fibrosis? In this case, the stiffness, the liver stiffness are higher, and steatosis also is higher. For these patients having these results, liver biopsy is not indicated to establish diagnosis of NAFLD. Ultrasound and B-mode and shear wave elastography may answer with one ultrasound ST exam on fibrosis staging and steatosis grading. Speaking about steatosis grading, much work has already been done, and some vendors have already presented tools in order to grade attenuation and steatosis. Attenuation of the ultrasound beam is the liver is not an independent procedure. Attenuation does not correspond to the fat content of the liver. Other hepatic tissue alteration, including necro-inflammatory process may infringe. Other tissue depositions should be excluded, including siderosis, using specific biochemical parameters. CAP, a software from a FibroScan, may quantify during the same examination fibrosis and steatosis, CAP meaning coefficient attenuation parameter, and is expressed in decibel per meter, grading steatosis. B-mode may use other properties of the ultrasound beam in order to grade steatosis. Speed of sound is a unique possibility that only the Arizona 7 offers already to its clients. There is a correlation between the speed of sound and the tissue type, and that has been observed in many studies. Certain speed of sound values give optimum B-mode image and in B-mode image quality. And then, having those measurements, liver steatosis can be differentiated from normal tissue. Liver with steatosis gives those numbers, low numbers. Normal liver gives around 5,050. This is the technique of how we proceed in order to have a speed of sound measurement. This is we start with a B-mode image, then we choose the ROI for the speed of sound measurements. We make a double measurement in different segments of the liver, and automatically the machine shows the number in meters per second. Those are low numbers indicating S3 steatosis, S2 steatosis. You see, as the numbers are going up, the numbers, sorry, here is S0. This is the results of our study. We have taken 37 normal, and those are 39 patients with NAFLD and NASH. And the result was that speed of sound, SSI, can differentiate between steatosis grade, but cannot differentiate between fibrotic stages. Those are the results and the accuracies with the cutoff values. Shear wave elastography is a tool in order to grade fibrosis and steatosis, but there are some issues if fibrosis and steatosis coexist, and that happens in NASH and in alcoholic liver disease. Steatosis, yes, interferes with stiffness measurements. There are 2 points here. Important grade 3 steatosis becomes an issue in challenging obese patients because shear wave elastography measurements are difficult to obtain and therefore unreliable. The second point is that important steatosis increases shear wave elastography measurements. The example of NASH is, we're going to discuss here, is an example where fibrosis and steatosis coexist and change during the long run of NASH. Starting from the normal liver, small quantity of fat in the liver, important quantity of fat in the liver. This is a crucial point where fibrotic tissue starts to evolve in the tissue parenchyma. From now on, and if the underlying cause, for instance, the alcohol, continues to act on the liver, there is important septa and fibrosis, meaning important fibrosis, and finally fibrosis. In the final stage, the cirrhotic case, there is important fibrosis and practically no steatosis. We have the possibility to go not only in this direction, but also in the other direction, because we know now we have drugs in order to treat fibrosis and steatosis, and of course having as first job to remove the underlying cause. We approaching in a period of ultrasound where steatosis is going to be graded using attenuation and the speed of sound. Fibrosis is going to be measured with shear wave elastography, and inflammation is going to be measured using another ultrasound beam property, dispersion. The third chapter of this presentation, we are going to discuss portal hypertension, which is a pathologic increase in portal pressure. in which the pressure gradient, meaning the pressure between the hepatic veins and the portal vein, if this gradient is increased above the upper limit of 10 millimeters of hydrargyros. There are many causes of portal hypertension named here, post-hepatic, intrahepatic, and prehepatic. The main cause for hepatic cause of portal hypertension is cirrhosis. And those are this is the mechanism of a provocation of clinically significant portal hypertension. There is increased resistance because of the cirrhotic liver. There is a corresponding splanchnic vasodilatation, several pharmaceutical factors, and finally increase the cardiac output to make increased flow and make situation worse. The complications of portal hypertension are gastrointestinal bleeding from gastric varices, as you can see here, but also ascites, hepatic encephalopathy, and kidney failure. In this presentation, we are going to discuss how color Doppler helps in the study of hemodynamics of portal hypertension. A color Doppler can diagnose a reversal or reduce a portal flow. It can very easily find out collateral circulation. The portal system dilation is very often. Studying with a color Doppler the portal, the hepatic vein, and finally splenomegaly is a morphological feature for grading a portal hypertension. A contrast-enhanced ultrasound has a role in grading a portal hypertension. There are many studies running. The only drug existing in Europe is Sonoview. Those are the microbubbles. Having the possibility, because the Zeus is only an intravascular contrast agent. Then, following the different arrivals time, hepatic artery arrival time, hepatic vein arrival time, and intrahepatic transit time that Zeus can calculate, we may have more arguments for grading portal hypertension. Shear wave elastography measures spleen stiffness, but it is different from measure and not the blood pressure in the portal system. This is a trial measuring the spleen stiffness before and after a prophylactic carvedilol therapy in cirrhotic patients with esophageal varices. We can see that this group of patients, because of this examination, we have been able to divide it in hemodynamics responder and non-responder. Portal hypertension grading using two kind of rules, as you can see, very similar. The rule of 5, dividing this scale of measurements in kilopascal from 5, 10, 15 to 20. From 5 meaning normal, 20 meaning clinically important portal hypertension, and we need to exclude hemorrhage for varices. There is a more recent vendor neutral rule of 4, from 5 to 10, from 5 to 9, from 9 to 13, from 13 to 17, with similar results. Liver stiffness matters not only for fibrosis grading, but also for portal hypertension, as you can see here. How about let's see how hemodynamics in cirrhotics and in cirrhosis and portal hypertension may be seen in ultrasound. This is, of course, a cirrhotic liver. Only this only this one image may make the examiner sure that this is a cirrhotic liver, but also passing in the hemodynamic phase, you can see dilatation of the portal vein, small varices in the abdominal fat in front of the liver, and also splenic varices, splenogastric or splenorenal varices, and all this to confirm finally that we have the possibility not only to see the varices, but also to have a shear wave elastography measurements, a pathologic shear wave elastography measurements, in this case more than 40, meaning that we can combine morphology, hemodynamics, and elastography in order to be sure that this patient has clinically significant portal hypertension. Is there a method for combining and weighing different ultrasound parameters? Chronic liver disease is a very complex illness. Not only the liver is involved, but many morphologic, histologic, biochemical, hemodynamic factors are influenced during the chronic liver disease long run. One single biomarker, like shear wave elastography, is not enough, is not sufficient for such a complex dynamic process. Steatosis and portal hypertension are ever-changing entities during the long run of NAFLD and NASH, and they also go long run of alcoholic liver disease. We may combine morphology, hemodynamics, and elastography, measuring parameters by ultrasound in order to have morphology parameters, hemodynamic parameters, elastographic parameters, in order to integrate all those information to a neural network. This is another way to present how morphological information, like liver nodulations here and here, like the status of the portal vein, hemodynamic information on the status and diameter of the portal vein, but also of the dilatation of the inferior vena cava and the right hepatic vein. And finally, of course, elastographic measurement on the liver and the spleen. In more schematic way, this is the neural network combining morphology, hemodynamics, and elastography measurements in order to grade fibrosis, steatosis, and inflammation. Concluding, shear wave elastography for fibrosis, steatosis, and portal hypertension grading. Yes, we can combine multiple parameters, but fibrosis, for fibrosis, shear wave elastography measurement is a reliable biomarker, but stiffness is not synonym to fibrosis, since other intrinsic and extrinsic factors interfere. Steatosis with speed of sound and attenuation are reliable biomarker for steatosis grading, but speed of sound and attenuation are not synonyms to the liver fat content. Portal hypertension, of course, shear wave elastography of the spleen is a reliable biomarker, but stiffness of the spleen is not synonym of the blood pressure in the splenic vein. That means that we need a tool, a weighting, multiple parameters. An ultrasound has the potential for collecting these parameters during a single and cheap examination. Machine learning is the tool for identifying associations between input parameters, morphologic, hemodynamic, elastographic, and output parameters, fibrosis, steatosis, and portal hypertension. Thank you for your attention. In front of those lions of Delos, Delos is a small Greek island, let's think about capacities and possibilities of ultrasound. We have already 3 lions seeing on the 3 possibilities of ultrasound. B mode for morphology, color Doppler for hemodynamics, and the third one for elastographic measurements. It seems that a fourth one is appearing for attenuation and speed of sound of the ultrasound beam for steatosis grading. Thank you very much. See you in the next Mindray webinar.
Good evening. It is my honor to speak here, and the topic for my speech today is esophageal virus assessment based on liver and spleen stiffness measurement by STE in liver cirrhotic patients. Portal hypertension and its related complications often occurred in cirrhotic patients. Esophageal varices is the most common complication of cirrhosis, and variceal bleeding is life-threatening and associated with high mortality even after effective treatments. At present, esophageal gastroduodenoscopy (EGD) examination is still the gold standard for assessments of esophageal varices, as well as the treatment of variceal bleeding. According to the clinical guidelines, once the patient is diagnosed with cirrhosis, it is recommended to take EGD exam as a routine screening. It will help to find out whether the patient has the risk of variceal bleeding or not. EGD examination is also the composition of follow-up stage if the patient has esophageal virus. However, EGD examination is invasive, high cost, and acceptance of patient is quite low. On the other hand, the early diagnosis of cirrhosis and widespread use of antivirus therapy reduce the risk of EV. Therefore, some EGD screenings are unnecessary. And in recent years, we are searching for non-invasive tests for the screening of EV. Ultrasound elastography is a non-invasive diagnosis technology. It is repeatable, convenient, and low cost, and also of high clinical utility. At present, the main technologies in clinical application are transition elastography (TE) and 2D shear wave elastography (2D-SWE). TE is an early technology and its value in predicting esophageal varices has been recognized by the guidelines. However, TE has some limitations. For example, TE is not suitable to be used in patients with obesity and ascites. 2D-SWE has appeared only in recent years. With the guideline of ultrasound image, the successful rate of 2D-SWE detection is even higher than TE and could be used in patients with obesity and ascites. In previous studies, liver stiffness measurement (LSM) is proposed useful for the assessment of cirrhosis and its complications. The 2015 Baveno 6 consensus presented the criteria for excluding cirrhotic patients with high-risk virus. Patients with a stiffness of less than 20 kPa measured by TE and a platelet count of more than 150 billion a year has a very small risk of display high-risk virus, and EGD examination could be safely avoided. But due to the limited studies of 2D-SWE, LSM measured by 2D-SWE for predicting high-risk virus has not been well defined. The 2018 elastographic guidelines put forward that the spleen stiffness measurement (SSM) is a potential predictor of high-risk virus. Several studies have reported that SSM may correlate better with high-risk virus compared with LSM, and the combination of LSM and SSM may make the prediction for high-risk virus more accurate. The spleen stiffness measurement appears later than LSM and is also more difficult than LSM. Thus, studies related with SSM is limited and more are needed. Therefore, we aim to utilize LSM and SSM measured by 2D-SWE in combination with other non-invasive tests to establish the prediction models for HRV in cirrhotic patients, presenting criteria to reduce the number of unnecessary EGD examinations, and to provide different suitable assessment proposals in different clinical situations. This is the study design. Cirrhotic patients without a history of variceal bleeding were enrolled in the study. We used STE to measure liver and spleen stiffness in all enrolled patients. STE is also a kind of 2D SW technology. And finally, those with reliable LSM and SSM results were included for analysis. In our study, all LSM and SSM detection was carried out by 2 experienced operators using STE. The instrument conditioning was referred to our previous researches and the recommendations of elastography guidelines. The field of view FOV was for the LSM detection was set 4 × 3 cm, and the diameter of regions of interest RI was set to 20 mm. And for SSM detection, FOV was 1.5 × 1.5 cm, and RI was set as 10 mm. Patients should fast for at least 2 hours before the detection. Patients were required to take the supine position and avoid deep. For each stiffness measurement image, we took these quality criteria. First, more than 2/3 of the elastography maps should be colored, and stability from motion in a period of time frames index should be 4 to 5 green stars. At last, reliability map index should no less than 95%. Respective fine measurements of LSM and SSM should be obtained, and the median value was reported. If there were at least 3 valid times of fine measurements, and with an IQR-M ratio no more than 30%, then the LSM and SSM results were considered as reliable. There were 115 enrolled patients in our study, and 107 was finally included in the analysis. HBV was the main etiology of cirrhotics. 62.6% patients displayed with esophageal varices, and high-risk varices was found in 29.9% patients. In our study, the successful rate of LSM detection was 91.33%, and the successful rate of SSM detection was 77.08%. In most previous studies, only patients with spleen thickness more than 40 mm were included for analysis. Thus, for further comprehensions, patients were divided into 2 groups according to the spleen thickness. One group is spleen thickness less than 40 mm, and the other is no less than 40 mm. For those with spleen thickness less than 40 mm, the successful rate of SSM was 46.3%. The others with spleen thickness no less than 40 mm was 95.6%. With the increase of degrees of esophageal varices, the average of LSM and SSM value will increase. The average SSM value of patients with EV or HRV was significantly higher than those without EV or HRV. In logistic regression analysis, we found that platelet and SSM was independent factors associated with varices, while spleen diameter, PLT, and SSM was independent factors associated with HRV. So we decided to build up these 4 models, including single SSM model, LSPS model, LSN plus PLT model, and the LSM SSM plus PLT model. ROC curves of these different models for predicting HRV were shown in the left. The LSM SSM plus PLT model has the best performance. The error under the ROC curve of this model was more than 0.8, and the cutoff value of this model is LSM less than 25 kilopascal. SSM less than 35 kilopascal, and PRT more than 100 billion a year. Here lists the cutoff values of these four prediction models. If the patient could meet one of these cutoff values, such as SSM no more than 22 kilopascal, LSPS score no more than 15, or LSM less than 20 kilopascal, PRT more than 100 billion a year, or LSM less than 25 kilopascal, SSM less than 35 kilopascal, and PRT more than 100 billion a year, then the risk of HRV is very low and EGD screening can be avoided. In our study, 75 patients was diagnosed without HRV. The best result is 34 out of these 75 patients fulfilled the cutoff value of LSM, SSM plus PRT model. That is to say, nearly 45.3% EGD screening could be avoided. For example, this patient was detected with a LSM 6.96 kilopascal and SSM 21.33 kilopascal, and PRT is 121 billion a year. The patient was predicted without esophageal virus, and it was confirmed by the EGD examination. As another example, the patient was detected with an LSM 22.75 kilopascal and a SSM 49 kilopascal and PRT 47 billion a year. The patient was predicted with high-risk virus, and it was confirmed by the EGD examination. Compared with Bavino 6 criterion and its expanding criteria, the LSM, SSM plus PRT model in our study could help to avoid more unnecessary EGD examinations. We built up 4 prediction models for HRV in this study. The predictor and performance of each model was quite different. It's important to select a practical model for the specific clinical situation. For most cirrhotic patients, if they can get the reliable LSM and SSM, we suggest LSM, SSM plus PRT model as the first choice, and the single SSM model as an alternative. And when failed to get a reliable SSM, LSPS model was preferred. At last, if the patient has a history of splenectomy, then the LSM and PRT model is recommended to be used. Since spleen is much smaller than liver, it is more difficult to measure the spleen stiffness. In previous study, before the T detection, researchers needed to confirm the location of spleen by the ultrasound examination, and due to the requirement of TE technology, SSM detection was only carried out in patients with spleen thickness more than 40 mm, but the reported successful was only about 70%. When using the SSI technology, the successful rate remained the same, while in our study, the successful rate was much higher. The reason why SSM is more closely related with HRV compared with LSM may be the theory that how LSM and SSM reflect the portal hypertension. SSM directly reflects portal hypertension. The change of stiffness is due to the congestions and other change related directly to the pH and independent of its etiology, while LSM is indirect. In conclusion, LSM and SSM assessed by 2D SWE are accurate non-invasive methods for predicting EV and HRV. Besides establishing and evaluating different models, we also get practical suggestions for selecting appropriate prediction model and criteria in the specific clinical situations. That's all. Thanks for listening.
Hello, everyone. We really thank you.
You can hear me, Candy?
Yes, I can hear you, Professor Sumpolas.
Okay.
We welcome back your speakers and everybody on to this webinar. And really thank you to Professor Zhang, Professor Sumpolas for your very informative lecture. We do have remaining time to take some Q&A. I don't have a definite format how our two speakers will take the Q&A. But I guess the best way is to take rotation. You can take your question one at a time. And of course, the question may be more applying to your own lecture, but the other speaker can always come in and give additional comment. Is that okay to both of the speakers as the ground rule?
Yes, Candy, of course.
Thank you, Professor Sumpolas. Now, Professor Sumpolas, actually, I have some question coming in from the audience. If you don't mind, can we first help out this question from the audience first?
Yes, of course.
Is that okay? Yes. The first one is actually a quick Q&A. Is saying that how can liver disease be classified in a simple and practical way? How would you want to address this question?
Yeah. Yes, very rapidly. You know, for every liver disease, we have we can classifying using clinical, biochemical, or imaging data in order to classify that. I can speak mostly about imaging data, saying that ultrasound and elastography has the advantage over other imaging modalities in order to classify liver fibrosis, liver steatosis, and portal hypertension, giving, let's say, an holistic view about what is happening in the liver and the portal system.
Thank you very much. You have also a second question. How common is renal dysfunction in children complicated along with liver disease? Please.
Yeah, it is not common, but you know, children are very easy to examine in ultrasound because of the fact that distances become low. We work only in 5 or 6 or 7 centimeters from our probe, and that makes our work very easy. There are congenital causes of chronic liver diseases of the children. We in these cases we see cirrhotic children also, and ultrasound is really the better placed, the best placed imaging technique in order to visualize the liver and the spleen for a morphology, hemodynamics of the portal system, and elastography measurements for both the liver and the spleen.
Thank you very much. Would you mind take one more question before I turn to Professor Zhang? Is that okay? Another question for you is like that. does stopping or reducing drinking improve chronic liver disease? Please.
Yes, of course. Yes, of course. As we know, alcohol abuse is one of the main causes for chronic liver disease. It is alcoholic liver disease. Of course, if we want to treat the effects that alcohol abuse is causing on the liver, we have to reduce or forget drinking alcohol. We have discussed during this webinar how alcohol is causing in the beginning fatty liver disease, then fibrotic tissue is proliferating and if the alcoholic abuse is continuing, cirrhosis is, let's say, the natural end of this long trajectory.
Thank you very much, Professor, for your help. And now I would want to turn our attention to Professor Zhang. Professor Zhang, can you help us with a question? Would you be okay to you?
Okay, just.
Thank you. First of all, thank you for your lecture and sharing us with your prediction model. Is really interesting. And your result actually go really well with some other similar study illustrating using shear weight elastography as a reliable technique for screening esophageal varices and cirrhotic patients to reduce unnecessary endoscopic exam. We were very much, thank you for sharing your data, particularly your cutoff value on LMS and also the SSM. So my question to you, would you mind share your experience in this study? What are the difficulties and limitations on SSM examination? And then please also tell our audience the reason why they need to be aware of when they do the SSM, examination. Would you please?
Yes, different from the liver stiffness measurement, in the detection of our liver and spleen stiffness measurement by the 2D SWE is very necessary to find a suitable intercostal image to avoid the large vessels and other structures. And compared with the liver, the spleen is much smaller and there may be less intercostal space allow us to choose. So it's more difficult to find a suitable image to take the detection. And in addition, the small liver thickness may cause more errors at the border of the FOV. Thus, we put the ROI to detect, they may get the unreliable results. So it may be so difficult for us to take the SSM detection. And when we use the 2D SWE to detect the spleen stiffness, we may qualify the image by the criteria we mentioned and the PPT, such as the motion of the reliable mass index and the stability of motions of terms of the index. That's my answer.
Thank you. So the stability motion index is very important too to get more accurate, KPA measurement.
Yes.
For the operator, right?
Okay.
Yeah.
Yes, it may be easy for the operator to judge if the image is reliable or not.
Excellent. So it's kind of like to overcome the difficulties and the limitation on the exam, isn't it?
Yes.
Okay. All right. Thank you. I will go on to ask Professor Sompoulos for his lecture question. And can I come back to you later for
yes.
some more questions on your lecture? Thank you.
Okay.
Thank you for your help. Professor Sompoulos?
Yes.
Can you help us? First of all, thank you for sharing your experience. Your new approach in imaging and grading, fatty liver, which is a global burden disease, isn't it? And steatosis grading using sound speed compensation. I thought it's a very creative, non-invasive technique, which is one of the key technology available on the Resonance 7. So would you mind share your experience if a new operator is using the sound speed technique to grade the steatosis? What do they need to know about the scanning technique? And how about patient preparation? And why? Could you help our audience on this very interesting technique, please?
Yes, may I show something? I'm not sure if everybody is seeing this slide. If not,
I think the engineer can switch to your computer,
okay.
Right?
You can see that?
Yeah, I can see your slides.
Okay, then let's start from the beginning, saying that this is a work in progress. It is true that this a feature, the possibility of the Resonance 7 to measure the speed of sound in a tissue, and namely in the liver, is a unique feature. But, we are working currently together with Mindray in order to make this feature more reliable and more easy to perform for the examiner. But till now, we can already begin saying the crucial things of the technique. First, the B-mode exam is something that it is the only way to start properly and the speed of sound measurement. Then you organize the positioning of the region of interest is very crucial. You have to diminish the distance between the probe and the liver to the maximum. That means that you have to place the region of interest, very near the capsule of the liver. And then the other thing that we have to mention is you have to assure immobility. Mindray is currently working on an immobility index in order to place this index also in the SSI technique. Immobility of both the probe and the liver is capital in order to achieve reliable speed of sound measurement. And also you keep doing minimum 2 measurements in different segments of the liver to be sure that your speed of sound measurements are reliable. if the technique you are going to follow is correct, then you are going to find low numbers around 1450 when the liver is very fatty, S3, and around 1500 with important fatty infiltration of the liver, and normal liver, the numbers are around 1550. That means that you have enough space between those numbers in order to grade liver steatosis. But let's speak about limitations also that exist. Although speed of sound seems to work with steatosis, we have no evidence that it works with a fibrosis. We could imagine that in the high fibrosis stages, speed of sound is possible. We could wait to be higher than that. It is not the case. Concluding, the technique is very crucial. We are now in communication with Mindray in order to apply reliability indexes and immobility indexes to make those measurements reliable. And if technique is correct, speed of sound can grade liver steatosis. Speed of sound does not work with liver fibrosis.
Excellent, thank you. So I have actually some clarification. From your model, looks like every 20 meters per second, you have a grading on the steatosis, and you have 5 grading of them. Are your study have any pathology for validation? Or is it the right way to say it? Would you mind share your experience?
Yes. As we all know, biopsies are practically non-existent in our days mainly because of elastography. But we have now MRI fat fraction, which is a reliable measurement for liver steatosis. With MRI fatty fraction, we can really grade liver steatosis per segment. That we use a fatty fraction MRI as a gold standard, as a reference standard, in order for our study, in order to compare performances of MRI and the speed of sound with B-mode ultrasound.
Thank you. One more quick question before I turn our attention to Professor Zhang. How about the idea of correlate the sound speed grading with the 2D shear wave, KPA? Do you think there's any correlationship study that's worthwhile to investigate?
We are not sure yet, but with the primary results we have already, with the preliminary results we have, we can conclude that liver fibrosis measurements, liver fibrosis status of the liver does not interfere with SSI measurement for staging steatosis.
Okay, got you. Thank you. All right, let's turn our attention to Professor Zhang for her help with another question relating to her lecture. Professor Zhang?
Yes.
Welcome back. Yes, you can help us on this question relating to your study model. Now, besides measuring the spleen size, what other ultrasound markers that your study used to discriminate the high-risk patient that is going to be a bleeder from a non-bleeder? Could you share that with us, and what are the reasons for you to look at those ultrasound markers?
Actually, in our study, the ultrasound marker, we just take the spleen size, like the spleen diameter, and we use it to establish the prediction model. But there are no other ultrasound markers. We only take the spleen diameter and the LSN, the liver stiffness measurement, and also the spleen stiffness measurement and the platelets to establish the model. It was based on our study results that the logistic regression analysis. We found that they were independent factors that associate with the variceal with the esophageal varice. So we just only take the spleen diameter with the other marker to establish our model.
Okay, all right. So what are usually the difficulty of getting an accurate spleen size diameter from your experience?
Pardon?
What usually are the scanning difficulty to measure an accurate spleen size diameter? Because this is one of your ultrasound marker, and you need to measure the spleen size, right?
Yes, we measure that.
You measure the length, the width, and the depth?
Yes, we just according to our previous study that we need to take in our just to take the ultrasound examinations and our practical clinical examinations and to choose how the site is suitable for our study.
Okay, great.
May I add something?
Yes, please, go ahead.
Okay. First, I would like to thank Professor Zheng, not only for the content, but also for the way she presented us her topic on portal hypertension. Thank you very much, Professor Zheng. To answer your question, Candy, you know, we usually use the longitudinal diameter of the spleen, which somehow it is an issue because if there is a real splenomegaly, the ultrasound B mode sector cannot include the whole spleen. Then we have to measure twice. This is an issue. We can solve that, but with an approximation. The other thing, we have concluded during a study that measuring spleen volume is more reliable than measuring spleen diameters. And there are now even in the market softwares and applications in which we can measure the volume of the spleen in a simple and valid way. I think that if we could measure the spleen volume, we have a better morphological parameter than measuring spleen longitudinal axis.
Thank you for your additional comment and insight. In that case, maybe we have to use the panoramic view to scan the spleen, isn't it?
And yes, and the panoramic view exists in the Arizona 7.
All right. I think we can stretch the time maybe for 1 or 2 more questions. And if you don't mind, Professor Sompoulos, I have a question relating to your lecture for your help. You did mention about portal hypertension. So in your experience, what kind of ultrasound markers that you use to grade portal hypertension? Can you share that with us and why?
Yes. The diameter of the portal vein is not a good, neither a reliable parameter. Splenomegaly, of course, it is a good, reliable parameter for portal hypertension. And then passing to hemodynamics, measuring speed of flow or volumes of flow in the portal vein are not good parameters for portal hypertension grading. One other crucial parameter is, speaking about hemodynamics, is visualizing varices as a collateral circulation. And we know where we can place the probe in order to visualize gastric or esophageal varices, splenogastric varices, and splenorenal varices. Also the recanalization of the paraomphalic vein. And third, most important measurement and parameter for a portal hypertension grading is stiffness elastography. You know, if stiffness of the spleen overpass 25 kilopascal, that means that practically even without endoscopy, we can avoid endoscopy in these conditions. If the measurement of the spleen stiffness is more than 25, that means that we have a decompensative portal hypertension with varices.
Great. We appreciate your extra help, Professor. I think time is up, but I have a closing question for both you and Professor Zhang. Whether you have any summary statement to conclude, but I'll go to Professor Zhang first before I come back to you. Is that okay, Professor Sompoulos? Okay, thank you. Professor Zhang?
Yes, I can hear.
Thank you so much for your lecture and your very detailed prediction model. I like to ask you if you have any closing statement that you want to share with the audience about your model. Before we say goodbye to everybody, you have any summary closing statement you want to tell us?
In our studies, I just think that the most important result may be the SSM is more related with the esophageal varices than the LSM. It may be reported that LSM, the liver stiffness measurement, is very accurate, could be helpful for the cirrhosis diagnosis and before the complication of the cirrhosis, then the SSM may be more helpful.
Thank you. Excellent comment. thank you for your help and thank you for your lecture. It's my honor and pleasure to meet you over the air. All right, now let's go over to Professor Sampoulos for his closing questions. Professor Sampoulos?
Yes.
Any summary statement to conclude from you, please?
For elastography has come as an ultrasound tool and has come in order to stay with us. Elastography is a very useful diagnostic tool, not only for the liver, but for other organs. But we are going to have time to discuss that in the future Mindray's webinars. Two more phrases about elastography. First word, technology. Choose a shear wave elastography that works well on the liver, and that is not the case for every vendor. Make sure that you make a good choice for the technology. A second word, technique. Train yourself. Touch the probe. Touch the patient, starting by a normal patient. At the beginning, you are going to have the impression that this thing is not working. It creates only nice colors, but without information. But please keep insisting, knowing that this is a very useful tool. Train yourself, not alone, of course. Find a good teacher, and now elastography is present in every country, and good trainers and teachers are near you. And then take your time. Take the probe. Of course, use the guidelines. You can find everywhere the guidelines, but nothing is going to teach you more than a real patient. Take your time. Ask your patient to be patient with you, and you are going to find out that even in difficult, obese patients, you are going to find a technique in order to have reliable shear wave elastography measurements. Thank you very much for your attention.
Thank you, Professor Sampoulos. You've been a great teacher. We really appreciate for all your help. And once again, I learned much more from you, from Professor Zhang, on the STE, STQ, and even the SSC now. And it's excellent. I'm sure the audience also, like myself, had learned much more. And I'm going to conclude this webinar by also a big thank you to the audience for their attention and also their interest. I hope they feel the same way as I do, that we are in a much better knowledge level to understand the technology on the retina in terms of 2D shear wave elastography, and bring better healthcare, providing ultrasound examination to our patients. All right, and time is really up. I'd like to say goodbye to all of you. Please stay safe. And Mindray UMaster webinar, look forward connecting with all of you again in the near future. Everybody say goodbye to each other until next time.
Bye-bye.
Thank you, everybody.
Professor Zhang, thank you. Bye-bye.
Thank you. Thank you, Professor Zhang.